to all the viewers around the world. Welcome to the 15th edition of the Endometriosis Explained, part of the teaching efforts of Worldwide Endomarch to raise awareness about endometriosis. Endometriosis, a social problem, and its effect on the humans. At the outset, we thank every one of you around the world for your assistance in your efforts to put an end to the dynasty of endometriosis and its chokehold on people, on patients, their families, and the society. Every one of you in any organization from A to Z, every person in any shape and manner that you are doing this, we thank you very, very much. A special thanks to all the endomarchers around the globe that they have been volunteering, doing all the work from the captains, president, ambassadors, every one of you and their family. We know how hard it has been for you. We know that you are volunteering to do this and you have no budgets. And I know some of you have asking if we can help. And I would like to let you know that Worldwide Endomarch is doing its best to invest in education in many universities, many big societies. And we thank you for your effort. And we are sorry that we have not been able to financially support you. And we want to acknowledge how much it has been difficult for you. And despite all of that, you are doing it. Example of it, as I said, the accomplishments of the Worldwide Endomarch France last month, Christina Zaparolo and President of France, Emmanuel Macron, that they contributed significantly. And we thank them again. Also, we like to thank the endomarchers and organizers in England. And also we want to give a shout out to the effort and the families of Sir David Amos, the member of the Parliament of England, that I had the privilege of meeting him and Secretary of Health in the Parliament and in a fundraiser to help the Endomarch organizers and endometriosis patients in England. Some of you may or may not know that, unfortunately, Sir David Amos, who was a wonderful, wonderful man and a crusader for women in general and women with endometriosis in England, unfortunately, he was assassinated by a ruthless person in England because of good he did. So we honor Sir David Amos and we want to thank him and his families for his contribution. So we will continue and be forward we go with all of your efforts. What you are doing really makes change. As you can see, endometriosis is more and more being heard about everywhere. Even medical societies are very helpful and they have started to be even more active. I just want to let you know you are being heard. Many medical societies, like American Society of Reproductive Medicine, is making efforts to raise awareness and education. We are lacking adequate surgeons to help you because endometriosis is a surgical disease and the best results for pain, for infertility, for organ dysfunction are by competent surgeons who are endometriosis specialists. And because of what you are voicing your concern, big societies like American Society of Reproductive Medicine, European Society of Human Reproduction, American Association of Gynecologic Laparoscopies, Laparoscopic and Robotic Surgeons Society in International Surgeons, and Society of Gynecologic Oncologists in the United States. These are all societies that are hearing you and they are gearing up to train more endometriosis surgeons. You have met some of them, Dr. Agrawal, Dr. Lee, Dr. Tavalloi, last time you met them, that they are specifically training to become surgeons to help patients with endometriosis thoroughly and properly the way that it should be done. That is all because of you and your interest. Because of your activities, the many medical universities, very big organizations, Hopkins, Harvard, Yale, Emory, Stanford, UCSF, Northwestern, Medical College of Georgia, University of North Carolina. These are some of the organizations that they were funded and they received awards from Worldwide Endo March to help them for their research, and we continue to elaborate. Professor Zandevan of Oxford University, she received that award, and also Professor Mizmer of University of Michigan, that they were heroes of the year 2020, they received awards. So these are all because of your interest and that we are making changes for endometriosis. Endometriosis is a social issue. It is not only a disease that causes pain, or for some people it is not really, it is a debilitating problem, and it is not always pain. And a major portion of the couples that they want to have children in the world, and they go from doctor to doctor and they tell them you are okay, all of your tests are okay, and your husband is okay, your partner is okay, and they don't get pregnant. These patients, they think it is something their fault. I have had patients, they say, but everything is okay with me. Is there something I did wrong? No, of course not. Endometriosis, in more than 95% of the patients that they come to us and they have no symptom and they want to get pregnant, they have endometriosis patient. They have endometriosis, and if this infertility patient, which is a social issue in countries in Europe, in Japan, right now, the population is going down. So the birth rate is going down. It is going to happen in the US the same way. So many of these infertility, these are because of endometriosis, far higher than medical societies know. We are in the forefront of this discovery. And I promise you, more and more, this issue would be recognized that we have to address endometriosis for infertility couples. What the mind doesn't know, the eyes don't see. Many of the infertility specialists around the world, they do not know the impact of endometriosis on infertility. And thus it is not being taught. But change is happening. Examples of our guest speakers today from New York and from here in California, I would let my brother, the co-founder of the Worldwide Endo March in New York, who is also a professor at Cornell and also NYU. He is, in addition being of an endometriosis specialist, he is a GYN oncologist. He will take over, and he would introduce his guest in New York, and I will join you again later. Thank you very, very much, all of you, for joining. And if you want to watch the previous session, go to webinars of endomarch.org and go to webinars. Thank you again for joining us. Dr. Farr Nezhat.
Camran, thank you very much. Good afternoon, good morning, and good evening, no matter where you are in the world. Today's session is going to be specifically concentrated about role of endometriosis on infertility. So endometriosis could affect the infertility in different ways. Briefly, could be some sort of anatomical destruction, like scar tissue around tube and the ovaries, that the egg doesn't get to the fallopian tubes, or the ovaries has large cysts and interferes with the ovulation, and that there are other issues that we will discuss it today. And we have two reproductive endocrinologists that will discuss, Dr. Talebian and Dr. Sanelu, and could affect the quality of the eggs, quality of the embryos, and also effect on implantations. So also we have, besides the infertility specialists, hormonal stimulation, and surgery, there are some other aspects of the endometriosis has to be addressed. And Dr. Mary Sabo, she is an acupuncturist, and she works with Dr. Talebian, is going to address the other support of these couples using the Eastern medicine versus Western medicine. So to start the session, we have from New York, have asked one of our dear patients, Nina Piro, that she is a patient of Dr. Talebian, Dr. Sabo, and had infertility, and Dr. Talebian thought she had endometriosis, and she was referred to me, and I did surgery on her, and she had endometriosis, and she was treated, and she has given us the privilege to be here, and I asked her to share her story with us. And after that, we go with Dr. Talebian and Dr. Sabo to share with you how they do their practice to help patients like Nina. Nina, go ahead.
Hi, I'm Nina Piro. Thanks for having me. I'm very honored to be here, and I feel like I'm back together with my whole medical team here. I am very, very grateful. I am 7 months pregnant today, and I wouldn't be if it weren't for Dr. Nezhat, Dr. Sabo, and Dr. Talebian. I'll just give a brief timeline, kind of my story. I got married in 2018, started trying to conceive in about April of 2019. And by kind of August, September, I sort of knew there was something, I had a feeling just something was off. Didn't really address it until the beginning of 2020. And the pandemic happened, kind of gone to my gynecologist. And I think I'd had a preliminary call with Dr. Talebian about maybe doing an IUI, did some preliminary testing in New York. But I was quickly kind of put in touch with Mary and I was out in Southampton for the summer, worked with Mary. And I also just want to say Mary and Carrie and her team, such amazing help, not only from, I had just lost my father. It was in the middle of the pandemic. I felt like Dr. Talebian and Dr. Sabo sort of saw me and were willing to listen to me saying, there's something wrong. I don't know what it is, but it just doesn't feel right. I'd never missed a period in my life. I had never really had bad period cramps. You know, it just was, everything seemed to be working, as Dr. Nezhat said, but kept on saying there's something off. We did an extremely successful retrieval with Dr. Talebian in January of, I guess it was 2021. And we did we got 9 embryos. I mean, it was a great retrieval. And we did a transfer in May 2021. It was unsuccessful. And for Dr. Talebian, I just don't understand. They were beautiful. There's just something else going on here. And I've been talking to Mary and Harry. And I just, I think throughout this process, I've really learned about advocating for myself, but I've also seen the advocacy work that can go on from doctors. And, you guys really listened to me and also saw things in myself that I probably wasn't seeing. So we did the surgery, me and Dr. Nezhat, in July of 2021. And then we did an embryo transfer in August of 2021, August 18th. It was actually on our wedding anniversary. I was like, there can't be any more pressure for this to go right, but it did. And I just, I always sort of had this feeling that something was off, and we kind of got to the root of it. And I will never forget Dr. Talebian on the phone with me that summer in 2020, kind of like the first conversation I had with her. I said, do you think it's my diet? Do you think it's something I'm doing? Am I running too much? She was like, are you asking me if you ate a cookie and that's why you're not getting pregnant? Like, no, it's not because you ate a cookie. And, this is something we need to figure out and get to the bottom of it. So I feel like we did get to the bottom of it, and I've had an overall really, really easy pregnancy, and I'm just knocking on wood to get through the next few months, 10 weeks successfully. And I hope that even that story can just bring light to just someone who's had the privilege of getting amazing medical care throughout my lifetime. Still, nothing was really flagged. Nothing was really talked about because I didn't really have any issues. So I just want to thank you guys for really seeing me as a person and collaborating. I think you're incredible.
Thank you very much, Nina. One thing that I like you to express that, and I like it that you listen to your body, as you said yourself, that you thought there is something not right. And then you wanted to help somebody to listen to you, and Dr. Talebian and Dr. Sabo listened to you.
Yeah, and I think that, to be quite honest, I think that after I had the surgery, I realized that there was probably, I wouldn't say necessarily pain with intercourse that was going on, but I was definitely more uncomfortable at certain points than I was sort of admitting to myself. That was probably one kind of listening to my body thing that I probably wasn't verbal enough about, and other than that, there were so few kind of signs, but I think I wish that at 30, 31, when I was sort of thinking about having a baby, I'd been more verbal about, like, there's just something that feels wrong. But a lot of that, I know something's wrong, is just, I don't know, I felt it in my gut a little bit. And I think I really, really want to thank Carrie and Mary. Carrie works with Mary out in Long Island, for also saying, the gut, there just looks like there's something off with the gut too, just a little slightly. And I probably should have been more sensitive to that, kind of some of those gastro too.
Thank you very much. These are very important for us as a surgeon, when the patient is referred to us to evaluate them for endometriosis. The way that we practice, number one, is to listen to the patient. And a lot of times the patient, when you listen to them, they will ask their own diagnosis. And you have to be focused and ask them the right questions. Not everybody has severe painful period. Not everybody has severe painful intercourse. You have just subtle things that you have to pay attention and ask the patient the right questions, and then you do proper examination. And also you have to rely on the experience of the referring physicians, because those physicians, they have had a lot of experiences that they know that, for example, and I asked Dr. Talebian and Dr. Sabo to explain their experiences when they think and they raise the flag to refer the patient. So that's the order for us. It is important to listen to the patient and do a proper examination before we do the surgery. And I will talk about the surgery later. So Dr. Talebian, would you please tell us what did you see in Nina that you thought you should send her to us? Thank you.
So can everyone hear me? I just want to make sure you guys can hear me.
Yes, yes.
Yeah, okay, great. Okay.
Yes.
So, Nina, I will say is a very, very sort of classic illustration of the endo patient who can go unrecognized for a very long time. And what I mean by that is she's, under 35, a history of, this unexplained infertility, ovulating every month, not getting pregnant. And interestingly, she, her primary OBGYN, or maybe it was myself, ordered an HSG, which is the uterine fallopian tube test, after she'd been trying for a handful of months. And interestingly, and again, there was the pandemic, so there was a little bit of her not being in the city the whole time, maybe, but nonetheless, she did an HSG, which showed a questionable blockage in one of her tubes. And that was a tip off to me. Okay, that's interesting. Why would a tube be blocked? Obviously endometriosis can do that, but nonetheless, there was various things going on. She tried on her own for a fair amount of time. And eventually, working with Mary and Carrie, sort of doing the Eastern approach, trying on her own, eventually came back to the city, and we kind of jumped into IVF. And this is the other tip off. She made they made, I should say, beautiful, high quality embryos that were chromosomally intact, like multiple from one round. And to me, that's another tip off, right? When I always tell people IVF is therapeutic and diagnostic. When someone has unexplained infertility and they do IVF and they have a very high attrition rate, and at the end of the process, they only have one good embryo or none, then we know the answer. This is an issue with chromosomes of egg, sperm, embryo, right? But when you have a, under 35 patient with unexplained infertility who makes gorgeous embryos, I always think there's something going on in that environment where this can't happen on its own and it's not implanting, and that could be endometriosis. And again, I think Nina kind of feels bad that she didn't really discuss her GI symptoms or pain, but I think a lot of women, like, you're used to it. That's normal for you. So when a doctor is like, hey, are you in a lot of pain? No, I'm not. I'm a big runner. So, I always go see the doctor. They're like, oh, you having pain? I'm like, no, I have no pain. And then they touch my foot and I jump up in the air, right? So I think at some point for a lot of women with endometriosis, their GI symptoms become normal and the pain they're having becomes normal. And so, and I remember speaking to Nina, I said, wow, you did beautifully. Let's go ahead and put one embryo in. When it didn't work, then I really knew. And at that point I said, let's hit the pause button. Listen, some doctors would think I'm crazy to refer you for surgery, but this whole thing wrapped together, I really think you have endometriosis. And I said, listen, you've got multiple beautiful embryos. We can keep at it and see if it works. But I really do think that this is what's going on. And I think even just for you and I to have the information and the data and the diagnosis, I think it'd just be helpful. And thankfully, Nina was, and again, I don't take surgery lightly. I explain to all my patients that there's very few surgeons I refer to for this because it is such a technical surgery, and you can talk about this later. Surgery has risks, but again, knock on wood, I know in your hands that they're, going to be taken care of and the endo is going to be treated. And in many ways, it's like the fastest course to getting to that pregnancy once they have those embryos already there on the side.
Thank you very much, Dr. Talebian. So Mary, tell us, what do you do with these patients from your perspective, working with Dr. Talebian, using your expertise?
Sure. So I'm a doctor of acupuncture and Chinese medicine. And so I specialize in fertility, and I have a team of acupuncturists that work with me. We have a location in Southampton on Long Island, and then we also have a clinic location in Manhattan that I now share with Dr. Talebian. And we have developed this kind of integrative approach where, you know, I work with women while they're trying naturally, and then I work with couples when they're undergoing IVF and other treatments. But I've been practicing about 15 years, and I've always loved Western medicine. And so right from the start of my career, I've always wanted to work in an integrative way. So using my tools of acupuncture, Chinese herbs, nutrition, lifestyle changes, evidence-based supplements with research backing them. Those are my tools, but my mind still kind of thinks in a Western medical kind of way. And so I really love, I can't do, in the state of New York, acupuncturists can't do blood tests or any sort of testing. And so I like to work with Dr. Talebian and her team at CCRM because they can do the testing that I can't see. So like I can't see the blocked fallopian tubes that might indicate scar tissue that indicates endometriosis. And so these are tips that I appreciate to get direction for my treatment plans. But Dr. Talebian sent me Nina pretty early on. I think we did some IUIs, right? And, you know, right from the get-go, when we see a patient, we don't just talk about fertility. You know, we do talk about the menstrual cycle, and it gives us a ton of information on the health, their overall health. So whether they have menstrual cramps or not, just gives us information on their underlying pattern. So women with a lot of menstrual cramps might also have a lot of other stagnation in the body. So constipation, headaches, pain elsewhere, like neck and shoulder pain, back pain. But, you know, endometriosis doesn't have to go along with those symptoms. And especially for us to treat it, we treat the overall body. So we also look at digestion, we look at sleep patterns, we look at energy, we look at their diet and how their body is processing it. So sometimes people think they're eating healthy. They might go vegan or they might be vegetarian, but we look at their digestion and their overall health, and it's not working for their system. And so we really work on a holistic level where we try to help the patient become healthy overall. But through my time working with Dr. Talebian and her team at CCRM, we've developed this integrative approach where we discuss cases. And so I'll come in and say, you know, thanks for referring so-and-so. Since we share offices, we can go chat face-to-face, which is great. And, you know, I'll give my side from the Eastern perspective of, you know, I'm seeing this in this case, there's like a weakness in the gut. I don't think she's absorbing nutrients well. I'm going to work on that and we'll see what happens. Or maybe a patient has done multiple IVFs and is getting poor quality embryos out. And so Sheeva will send me those patients too, and I'll work with their diet to decrease inflammation, which is a big part of endometriosis, which I'm sure we'll talk about. And we'll try to decrease the inflammation using antioxidants and herbs and acupuncture, changes in diet. And then we'll repeat an IVF. And we often do get improved results with subsequent embryos, but occasionally we won't. And then, you know, we'll kind of switch gears, and that's when we might send someone to surgery. So in Nina's case, she made beautiful embryos. And she had a lot, right? And so there was also, you know, sometimes I think we'll get tipped off with endometriosis when it's a young woman and she has decreased ovarian reserve. She's not making that many eggs and they're poor quality, and she's like 32. That's another tip off for us where we're like, what's going on here? Why are these eggs so poor? And, you know, we'll do our team approach and then kind of powwow on next steps. And sometimes that is surgery to explore for endometriosis.
Thank you very much, Dr. Sabo. Dr. Talebian, I will ask you one more question. One of the questions that always patients will ask, and if I have the surgery, the surgery could decrease my ovarian reserve, and they're afraid to have surgery. And unfortunately, some infertility specialists have created this fear in the mind of the patients. What is your experiences? And I would, of course, discuss with my surgical approach. But
Yeah.
what are your experiences? Thank you.
Yeah, so I do think, again, there is, unfortunately, there is some literature out there that seems to be pretty outdated, where surgery did potentially compromise the ovarian reserve, right? When you think of surgeons who are, doing cystectomies and really removing a lot of that ovarian tissue, then of course that can lower the ovarian reserve. But, again, I like to look at things from a historical perspective, and I think, right, surgery has become so much more successful nowadays, right? We, as the fertility doctor, I used to do a lot of surgery when I've been during fellowship and immediately post fellowship, but a lot of the techniques we used are outdated. The equipment is outdated. So essentially, I'm thinking, I'm a fertility doctor. I'm doing egg retrievals and embryo transfers every day, and I'm operating once or twice a month. There are surgeons that now operate, multiple days a week. The equipment is changing. The technology is changing. I don't think the patient's best interest is for me to do this surgery anymore. And I really passed it off quite a while ago, only because it is very important that whoever is doing that endometriosis surgery, A, can recognize the endometriosis, and B, is highly skilled to be able to treat the endometriosis without affecting the ovarian reserve, without really removing a lot of that healthy ovarian tissue, and at the same time, not injuring other structures. So what I tell patients who do their research online, I found this study that showed, lower AMH after the surgery. I say, well, you know what, you have to take that understanding that is, who knows who was doing the surgery? Were they really a highly skilled surgeon? When is this data from? Unfortunately, our literature, I think, is really outdated and not very accurate when it comes to this, which is, again, why there's a handful of people, I think, in the tri-state area who I think are very, very good at this. And so it's really important who you go to for the surgery, because yes, I agree. If you, maybe don't necessarily see a surgeon very skilled at endometriosis surgery, then your ovarian reserve may be compromised after the surgery.
Thank you very much, Dr. Talebian. So I just want to mention the surgical approach for endometriosis. As Dr. Talebian mentioned, the first aspect is to recognize the endometriosis. When you do surgery, which is right now, it is laparoscopic surgery, or some people, they call it robotic surgery. It doesn't matter, it is laparoscopy. And there are few important things that you should keep in mind. Number one is that you recognize the endometriosis, because endometriosis lesion could be different colors, different patterns, different areas of the pelvis, on the ovaries, on the back of the uterus, even sometimes towards the upper abdomen, on the diaphragm, on the appendix. So this has to be recognized first. And the second thing is that how to treat it. As Dr. Sabo mentioned, endometriosis causes inflammation. And the important thing is to remove it thoroughly. When you remove them, because this endometriosis, we call them implant or lesions, are sticking to different parts of the body, on the ovaries, on the bladder, on the bowel, ureters. So you have to keep in mind why you are removing them, you do not damage that organs. And when it comes to the ovaries, the goal is to treat the endometriosis, but in the same time, do not damage the ovary. So we know excising the endometriosis is very, very effective, but when it comes to the ovary, you have to be careful that not you chop off a piece of the ovary. You treat the endometriosis thoroughly without damaging the ovary. And that is when I talk to my patients and they bring the subject up, I will take my time explaining to them that that is true, that excision is good, but on the ovary may not be the best options. And then you have to treat it with other modalities thoroughly without removing a piece of the ovary. The ovarian cyst, this is different stories. You have to remove the ovarian cyst called endometrioma or chocolate cyst without not damaging the ovary, because you don't want to leave cyst behind, because sometimes this cyst could have potential to become cancerous. So you have to keep all of these things in mind. It is not when we do surgery for the cancer and we want to remove the cancer, that is one approach. Endometriosis, also you have to keep in mind the effect on on infertility, and also take care of the disease that the patient becomes pregnant, or if she has pain, adequately remove it to become pain-free. So I think, Camran, if anybody has any question for Dr. Talebian and Dr. Sabo and I'd be more than happy to answer. Otherwise, I think I pass the podium to you.
Thank you very much, Farr, and thank you to your wonderful, wonderful guest. It was outstanding and wonderful information, and I appreciate it very, very much. All of us appreciate it. Thank you. I would like to switch to our friend, Dr. Sunny June, and Alyssa Langner and her husband, Corey, and her son, Diane. And I would start with Alyssa. And Alyssa is a mutual patient of Dr. Sunny June with her husband, Corey, and the son, Liam. And we would start to say their story. You look how wonderful your son looks like. Oh, he says hi to you. Hi, Corey. Hi, Alyssa. And then we will proceed from there. We have been here fortunate, as my brother Farr has been to work with Dr. Talebian. Here I'm working with another forward-thinking reproductive endocrinologist, Dr. Sunny June, who, like her partner, Dr. Tazuka, and her friend, Dr. Kelly Beck, and Dr. Evazadeh, and Dr. Talebian, and she is able to diagnose and pick up patients with endometriosis. And we have been able and grateful to be able to help many, many couples like Alyssa and Corey and Ryan. So Alyssa and Corey, why don't you start a little bit of your story? We are anxious to look to hear it.
Thank you for having us today. Yeah, my name is Alyssa, and this is my husband, Corey, and this is Liam. He's our little miracle babe, and we're just so grateful for these amazing doctors who have made such a difference in our life and helping us start a family. So we, when we first got married, after a few months of trying naturally, probably about 8 months, we decided to, sorry, he's quite a busy toddler. After about 8 months of trying naturally, we decided to meet with Dr. Jun. And, my cycles were always long, and but there was nothing out of the ordinary. I didn't have extreme pain with periods. I really ultimately felt like, I had a healthy body in general, and it was really confusing to me why we weren't getting pregnant. you know, we did a couple of IUIs and they were not successful. And so Dr. Jun suggested that we consider moving forward with IVF. And one of the tests, well, so we ended up doing the Receptiva test, which was such an important test. And I'm so grateful that she suggested that. It did come back positive for several markers of endometriosis. And we decided to move forward with an IVF cycle, and we had great success and were fortunate to freeze several embryos. But she immediately said, I've got to refer you to see Dr. Nezhat. He's the best of the best. And it'll be really important that you get his insight on what's going on and you know, with your body and endometriosis. And so we're so grateful that we met you, Dr. Nezhat, and you were very thorough from the very beginning and really listened to us. And, you know, we were desperate to do anything to help us start a family. And I definitely feel like you and Dr. Jun really came together as a team to help make the best possible outcome for us. And I remember during that first consultation that I had with you that you said, you know, you could try to treat it with hormones of some sort, but you never really know until you go in with surgery how invasive the endometriosis could be. And I decided, why even take a chance? Let's just do the surgery. And I'm so glad that we did. You discovered that endometriosis was everywhere. I had it stage 4, all over my bladder, uterus, fallopian tubes, bowels. There's just so many different, I'm sure you can speak more to that, but it was fascinating. I remember when I came out of surgery, you said, I'm so glad that we did this. It was quite aggressive. It was stage 4 endometriosis. And again, I felt like I presented as a person that would not have endometriosis. I didn't have any of those typical symptoms. So yeah. And do you want to add anything, Corey?
Yeah. And then after the surgery, Dr. Nezhat came and put his hand on my shoulder and he goes, you have to be careful now. She's going to get pregnant. And guess what? We got pregnant with Dr. Jun's help. And now we have a very active, very tall little boy that's taken over our life. So thank you, Dr. Jun, Dr. Nezhat. It's been a blessing and appreciate everything you did.
Yeah, thank you so much. Yeah, and we were able to move forward with IVF successfully after the surgery, and Liam's here today because of that. So thank you both. And thank you.
Well, thank you very much, both of you. And Liam looks like both of you are very active. And yes, you know, the issue of Alyssa's story and Nina's story touches the issue that they didn't come for pain. The issue that they had not looked for that option had it not been the issue that they wouldn't get pregnant. And one important issue for endometriosis, as I mentioned, is a surgical condition, is when you treat it very thoroughly, you also, hopefully you decrease the risk of cancer associated with a patient with endometriosis, because patients with endometriosis, they have 2 to 3 times higher chance of cancer, and that treatment decreases that. And yes, who was the person who did a lot of this pioneering work in relationship to cancer and endometriosis, and that is Dr. Farr Nezhat, that his work was groundbreaking in this area, and he's devoted a lot of his work in this area. He may want later to say something, but I next proceed with Dr. Sunny June, and I'd like Sunny to express her opinion about patients with endometriosis and her thought process. I know after she said, no, look, this patient, they get pregnant and here and there. So we would appreciate it, Sunny, if you give your opinion. And I told you before, it has been a pleasure to work with Dr. Sunny John, a very brilliant REI, Dr. Jo?
Thank you, Dr. Nezhat. And thank you, Alyssa and Corey, for sharing your story. And Liam is absolutely adorable. Whenever I see a couple or a patient, a lot of times it's just mainly the fertility issue, but plus or minus this classic symptoms of endometriosis, whether it be painful periods, pain with sex, pain with bowel movements, but a lot of them don't really complain of anything. And so when straight off the bat, patients complain of, oh, I have severe pain with periods, then big red flag, right? Endometriosis. And even in those patients with severe pain, they go to their annual exams with their gynecologist, and I ask them, hey, has anyone brought up the possibility of endometriosis? And they'll say, no, they just tell me to be on birth control pills, or they tell me to take, NSAIDs, Motrin, or Tylenol during my cycle, and I'm able to manage it. So it has never really come up. And so when patients do complain, or they note in their little questionnaire at our initial consultation that they have severe pain, then that is something I really focus on at the initial consultation. And like both Dr. Nezhat and have been saying, is that endometriosis is a surgically diagnosed disease. It's not a clinically diagnosed disease. So regardless of whether you have symptoms or lack of symptoms, we don't know until these patients undergo surgery. And also, we don't know the severity of the disease, that the symptoms don't necessarily correlate with the severity of the disease. We have seen patients with severe symptoms, and then they undergo surgery and have stage 1 to 2 endo. And then there are patients who have absolutely no symptoms and just failed IVF cycles, and they end up having severe endometriosis. So when patients do complain of severe pain, then we focus on, maybe we should look into this first, or, after banking embryos, but let's look into this and let's focus on this. But in patients who have no symptoms or just mild symptoms, someone like Alyssa, then there is a screening option. And we use this test called Receptiva. And Receptiva is an endometrial biopsy test that checks for 3 markers. It checks for 2 of the markers for looking for endometriosis, such as BCL6 and beta-3 integrin. And then the other marker is checking for what's called endometritis. It's a different disorder that's looking for infection in the uterus. But for Alyssa, the endometriosis one did come back positive. So in this scenario, what are the options? Well, do we further look into this and get it definitively diagnosed with surgery? Or do we do IVF, bank embryos, and there is that medical option, which is a hormonal suppression, but that doesn't really diagnose or definitively treat it. It just temporarily suppresses it. And so I usually tell my patients, you know what, just go see the endometriosis surgeon, the specialist, because they'll do a more thorough exam. They'll do another ultrasound, and they will let you know if they think that you definitely do have it or not. And luckily, Alyssa and Corey listened to our recommendations and went to Dr. Nezhat, and she did end up having severe endo. And so in patients where it's mainly fertility issue and kind of lack of symptoms, and they're not convinced that they may have endo, then we start off with maybe that screening test. And then for patients who clearly have symptoms, then I actually just send them straight to the endometriosis specialist. Another key thing that Dr. Talebian also mentioned is it's really important for the endometriosis to get very well treated. And I know a lot of gynecologists are very surgically skilled, but endometriosis specialists see, and they perform these surgeries day in and day out. And that detecting or identifying endometriosis that can present with at various stages and various colors and different lesions, if the surgeon is not as experienced, they may miss those. And as I mentioned before, we don't know what stage the patient will have until the surgeon goes in. So I've also have had unfortunate cases where we would send the patient back to their gynecologist, and they would undergo the surgery, but it would end up being stage 4. And when it's stage 4 and they don't feel comfortable, then they need now a repeat surgery. So we also don't want that to happen, where patients have to undergo 2 surgeries. And that's why it's so important to send patients to surgeons who can take care of stage 4 endometriosis. That can be stuck to bowel. It could be bowel-related surgery. And Dr. Nezhat does such a thorough surgery that he does proctoscopy, cystoscopy, like every aspect of where the endo could be. He does such a thorough job that I know that if a patient does go to an endometriosis surgeon like Dr. Nezhat, they will be treated completely. And one thing Dr. Nezhat likes to tell my patients afterwards, like, now you can try naturally before doing the transfer. Just try naturally for a few months. And some of my patients have gotten pregnant naturally. And it's been such an honor to work with surgeons who are extremely skilled. And I always tell Dr. Nezhat he can't retire, because what am I going to do with my endometriosis patients? But yeah, Dr. Nezhat, thank you for always taking such good care of our patients. And I do think that endometriosis is not as much talked about as it needs to be, even in our fertility field. So I'm so glad that you're doing this webinar to bring more awareness. And now I'm also even talking to my egg freezing patients about this too, because egg freezing, they just think that, okay, well, we'll freeze some eggs. And then when we talk to patients about their symptoms, I'm like, you may have endo, and you probably should get this properly managed up until, when you're ready to have a kid, because you don't want to go like 5-10 years without this disease getting managed and then getting worse. And when you're finally ready to start a family, and then having severe disease. So I'm now trying to be very proactive with my egg freezing patients too, when they come to me for consultation. And if they have this question of, symptoms, or I think that they may have endo, then to really talk to their OBGYN or go see an endometriosis specialist.
Dr. June, thank you very much for your thorough explanation. We really appreciate it. There is a question on the chat that I'd like you to address it. Can you see it, or should I read it? Do you see it on the chat?
Oh, I see. 1 second. Oh.
From Zizi Mode about some recent research paper found there is no benefits in IVF outcomes. I have my own opinion. I'm sure that the Camran Nezhat has too, but I wanted to see what you think.
I can't, for some reason, I can't see them. I think was it a direct message for the?
No, it is on Q&A answer on the right.
Oh, Q&A. Okay, sorry.
That's right.
I'm not very technically savvy. Okay, 1 second. So some recent research papers found that there is no benefit in IVF outcomes of patients with endometriosis who had laparoscopic surgery to remove endo versus those who did not have surgery, especially that any surgery might have side effects like making new scars and adhesions. What is the best treatment for a patient with endometriosis who wants to conceive? In what circumstances the surgery would be recommended? How about the deterioration of egg reserve as a result of endometrioma removal? Even some papers did not report egg quality improvements following the surgery in ovaries and removal of endometrioma. Wow, that's a big question. Okay, so I'll address some aspects of it, and maybe Dr. Nezhat and Nezhat, you can chime in. So before, I mean, surgery is not something to be taken lightly. I completely agree with that. And I try to look at the entire picture. So if a patient like Alyssa, who has very good number of embryos, and the patient is concerned about surgery and the potential risks. And first, let me step back. In terms of being concerned about the risks of scarring and damage to surrounding organs, and that's why we stress again how important it is to have this surgery if the patient decides to have it done by a specialist, because endometriosis is a very tricky disease. It's, you know, there can be lots of scarring in there that is scarring some very important organs such as the bowel. And so you do want to have an excellent surgeon to be doing this. And so I'm not sure about these studies, who were the surgeons, et cetera, but there are a lot of surgeons out there that say that they are endometriosis specialized, but are they truly doing multiple difficult stage 4 endo surgeries day in and day out? I don't know. And so it would be dependent on, I would not send patients to just any surgeon. I would have to feel confident. And I always tell my patient, since I was a resident, I've been in Dr. Nezhat's cases and I know how he operates. So that's why I trust him to take care of my patients. I said, I would send my family members. I would even go if I had endo to Dr. Nezhat. So it really depends on the surgical skills to have, in terms of potential complications that patients can have. So like I said, I look at the big picture. If the patient only has one embryo and they're not going to do any more IVF cycles, then I really try to explain to the patient that if we're going to do everything possible, then, and we think that you do have endometriosis, then surgery probably may be the best option, because it will not only treat, but it diagnoses. And so the most frustrating thing is when we transfer a genetically normal embryo and they don't get pregnant. Then we're scratching our heads. What happened? This beautiful embryo did an implant. What happened? And if the patient has, let's say, surgery and they have stage 4, and we transfer an embryo and doesn't conceive, let's say, then we have to also think about other options or other pathways to kind of figure out what else could be going on. But if you don't have that diagnosis, and if the patient had stage 1, then we know that probably endo may not have been a significant contributing factor to her fertility issue. And so it's just good for us to know how to plan for the future, depending on what the outcome may be with our treatments. And so just to have that diagnosis is key. And then, as I mentioned before, getting that treated. And endometriosis can come back. And so knowing what the severity is, we will then know how to manage, even after the patient gets pregnant and delivers, that if they have severe disease, I tell patients, you need to go straight back to Dr. Nezhat and ask what type of suppression you need to be on until you're ready to have your second child or your third child. And so I kind of answered some questions, some of those questions all at once. But in terms of the deterioration, I think Dr. Talebian also mentioned that too. Yes, with the endometriomas, if you're not careful in removing those cysts, can you remove some of the healthy ovarian tissue and diminish? But then I also tell patients about the pros and cons. We don't automatically, Dr. Nezhat has been great. He would tell me, oh, this patient has a 2-3 centimeter endometrioma. why don't you bank embryos first, and then I'll do the surgery afterwards. He doesn't tell patients we need to get this removed, and because he also understands that there could be that decrease in reserve. But then if the patient does IVF and we get poor quality embryos, and then I discuss it with Dr. Nezhat, and we think, you know what, if this patient has poor quality embryos, maybe could the endometrioma be affecting the egg quality? And I know endometriosis surgeons believe in that. And so then we say, okay, well, why don't we have them do the surgery first? They get all the endometriosis treated, then we do subsequent cycles, and we have seen improvement. Anecdotally, we have seen improvement. And it's so surprising to see sometimes higher euploid rates, improvement in the grades of the embryos. So we have seen that anecdotally, but we don't take surgery lightly. I don't think even Dr. Nezhat's take surgery lightly, but it can be extremely beneficial for our endo patients.
I like to, oh, sorry, I'm sorry.
No, I just want to thank you, Dr. John. There's only one more last question that you may want to address it. And then the question is, can I ask what is the right amount of recovery time after surgery to optimize my next egg retrieval? I usually, and Dr. Talebian, when they send the patients to me and I do the surgery, we put them on hormonal suppressive therapy like birth control pills, and then I will send them back to when they want to start the next IVF. So what is your experiences? When do you start the next egg retrieval after the surgery?
So do you want me to address, or do you want me to, let me say something here. I want first to thank the brilliant answers of Dr. Sunny June and the way that she really hit the nail on the head. The best things have to be done properly. And a pilot who is very experienced, who can take a big jumbo jet very safely around the globe. But if he give that big jumbo jet to an inexperienced pilot, you are in danger. Surgery is like that plane that has to be done by a very experienced surgeon. If the surgeon is not experienced, they would have results of the person who had that question. I bet you many of those surgeons who do those studies, their experience is very, very limited with endometriosis surgery, and they are not adequately trained to recognize and treat the patient, because our experience is 100% different than that published paper. What the mind doesn't know, eyes don't see. You cannot deny the numbers and the facts. Dr. Sunny June, Dr. Talebian, and Dr. Evazadeh, Dr. Beck, that we routinely work with, are brilliant infertility specialists, Dr. Sabo, that we work with them. They are dedicated to their patients, and we see these patients routinely, and numbers don't lie. I have my fellows, Dr. Shruti Agrawal here online, Dr. Deborah Lee online, and I know Dr. Farr Nezhat's fellow is online. They are doing the research. These patients, they get pregnant much better after the surgery with repeat IVF, or as Dr. Sunny June said, spontaneously, many of these patients, they get pregnant. But the surgery should be done properly, correctly. If the surgery is not done properly, of course it could cause harm. anything should be done properly. That is why we are training surgeons. The lack of adequate surgeons, unfortunately, is a harm to the patient, because endometriosis is an aggressive disease, is a progressive disease, is associated with higher rate of cancer, and you cannot simply put your head in the sand and say it doesn't exist. Simply, it is, if you have a headache, it is okay to take Tylenol. But do you know if the headache is because you are talking too much, or it is allergies, or it is a cancer? In cases of the cancer, it's better to diagnose it early because you might be able to do something. And that is the problem with the studies. We do not have enough surgeons to treat endometriosis. Endometriosis does not respond well to doing nothing, and it could progress. It could compromise the ureter and kidney dies. It could compromise the bowel. It could grow on your nerves. And even if it has no symptoms at all, ultimately, these patients, they have a higher risk of cancer. If they may end up with higher risk of ovarian cancer. So we should not put our hand or head to sand and ignore it. In our hands, in our data, when you treat them well, the infertility couple, they get pregnant and they need help. Somebody should help them, and studies should be done by proper place. Come and see what we are doing with our data. Our fellows are doing all the research, and the results are there. So we need to address the issue of endometriosis properly. We have had wonderful, wonderful guests. I know we have gone a little bit over, but I'd like to thank all the participants, Dr. Farr Nezhat, Dr. Talebian, Dr. Sabo, Nina, Piro, and Dr. Sunny June, and Alyssa, Corey, and Leah, and also all of our fellows, Dr. Agrawal, Dr. Lee, and Dr. Sabo, who has been Dr. Paul's fellow, who have been online, and also our organizers at the Worldwide Endo March, Dr. Zoe Pennington, and the rest. We thank you very, very much. This is a very important issue. I know I am talking out with passion, but again, the passion is to raise awareness about endometriosis, find out what is the best treatment. Ideally, we hope that we prevent it at all. And we thank you very much again. Next month is going to be the Worldwide Endo March. All the celebration is going to be the whole month, and all the progress that we have done. Many of you around the world have sent your videos. Your participation is going to be virtual. And the month after, we will continue this address with another REI from LA, Dr. Kelly Beck. I thank you very much, and forward we go. Bye-bye.
Thank you very much. Have a nice weekend. Thank you.